I would like to officially welcome you to Wednesday Wellness. It is a free live educational series presented by Trinity Health Medical Group. Thank you again for joining us this evening. Before we turn it over to our presenter, Dr. Yam, we would like to just provide a few reminders. This presentation is being recorded. You will receive a link to that recording over the next several days. If you have questions, please use the Q&A bubbles down at the bottom of your screen. They're usually in the middle to the left side. When we get to our question and answer portion, your questions will be read aloud and then answered by our presenter. And without further ado, I would like to introduce Dr. Julie Yam, who is a gastroenterologist with Trinity Health Medical Group Gastroenterology. Thanks so much, Dr. Yam, for being here this evening.
Thanks, Brittany. My name is Julie Yam. I'm one of the newer providers with West Michigan Gastroenterology. I joined the group a little over a year ago now, and I was practicing in Southwest Michigan prior to joining the group, but I'm very happy to be here. There's a big need for gastroenterologists in this area, so I was happy to come and fill that void that you guys had here. So March was Colon Cancer Awareness Month, and I just wanted to go over a very brief overview of colon cancer prevention, because it's such a prevalent thing that is easily preventable with colonoscopy screening. So I'll just go ahead and move on with that. So basically, it's just going to be some general information about colon cancer to start with. I'll go over the risk factors, signs and symptoms to watch for, the ways we screen for colon cancer, and treatment options that are available if you or someone you know were to be diagnosed with colon cancer. So moving on to the general information about colon cancer. It's the third leading cause of cancer death in men and women. And as I said before, it's very preventable. And if you catch it early, treatment options are very good at curing colon cancer. So it's very important to get screened for colon cancer if once you reach the certain age. It is the most frequently diagnosed cancer among those aged 65 to 70 years old. And approximately 150,000 new cases are diagnosed every year. Men have a slightly higher lifetime risk of 1 in 23, and women have a 1 in 25 lifetime risk. So basically for colon cancer, it starts off as little growths on the inside of the lining of the colon wall. We call those polyps. So just like you can get little growths or little moles on the skin, on your skin, those can grow on the lining of your colon. And that's what we're looking for when we do colon cancer screening. There are different types of polyps. The two most common types are hyperplastic polyps and adenomatous polyps. Now, the hyperplastic polyps have no cancer risk, but adenomas do have a slight risk for colon cancer, meaning that if these adenomas are left in place, they can continue to grow. And if they were to continue growing, some of them will grow into colon cancer. So it's important that we catch those early. And then there's different kinds of adenomas: tubular adenomas, sessile serrated adenomas, tubulovillous adenomas. These adenomas are the precancerous ones that we usually find the most. And I have them written out in increasing risk of colon cancer. So the tubular adenomas have a less or a lower risk of developing into colon cancer than a sessile serrated versus a tubulovillous. And then low-grade dysplasia and high-grade dysplasia, that's when we start to see that now we are seeing a much higher risk of colon cancer. Once you get into these stages of polyps, these are very high-risk lesions, and these need immediate intervention if these are found. Precancerous polyps do take several years to grow into cancer, as much as 10 years and even 15 years for some studies. And so this is why when we do colon cancer screening, we usually will say 10 years if no polyps are found, just because it's such a slow growing cancer. Now here's a graphic of polyps. So they start off very small, almost like a little mole or a little bump on the lining. And then as they grow, they can start to transform into more sinister lesions. And then this is where we start seeing that dysplasia that I had mentioned earlier about those being much higher risk lesions. And so these are the ones we want to get rid of immediately. And as they continue growing, those areas that are highly suspicious can start to now grow more into that lining and become cancer. So our goal is to catch these lesions early when they're very small, because these are very easily removed during a colonoscopy. And when you start getting into these higher risk lesions, especially here where it's this adenocarcinoma, which is another name for cancer, this would require surgical removal. Now, risk factors for colon cancer. The biggest risk factor that most of us know is family history of colon cancer. Your biggest risk is going to be in a first-degree relative, meaning a sibling, mom, or dad. A second-degree relative, like a grandparent, may increase your risk a little bit, but not as much as a first-degree relative. Any underlying inflammatory bowel disease, such as ulcerative colitis or Crohn's disease, will increase the risk for colon cancer just because that inflammation will cause a little bit more reaction in the colon and can cause these polyps to form. Obesity or metabolic syndrome. Having an overall poor diet, especially that's high fat, including red meat, and being low in fiber. In general, a high fiber diet is good for overall colon health. Smoking does increase polyp formation, as does alcohol. Signs and symptoms to look for. Rectal bleeding is the most common sign that patients will come with. And this would be persistent rectal bleeding. So spotting intermittently once every couple of months, things like that. That's not as concerning as having rectal bleeding on a consistent daily basis. Abdominal pain, this is on the vague side and doesn't necessarily mean that you have colon cancer, but it is one of the signs. Persistent change in bowels, whether it be diarrhea, constipation, or a change in the caliber of the stool. Usually pencil thin stools is how people will describe the change that they see. And this is because as the cancer is growing, it usually grows into the opening of the colon wall, shrinking the area that the stool has to pass. And so it compresses that stool and makes it more pencil thin. Unintentional weight loss, meaning losing weight, but you're not trying. And then having iron deficiency anemia. And this is going to be something that would be seen on routine labs with your primary care provider. So colon cancer screening with colonoscopy. Why do we do it? So as we're talking about in the beginning, the whole thing we're doing is trying to prevent colon cancer from developing. We want to catch it early if it's already formed. And that's because it's a lot easier to treat and you have a better chance of cure if you do catch it early. And this is becoming a big topic as far in the GI world, because we've been seeing that cancer rates have been increasing in younger people. And so it used to be that we would do colon cancer screening starting at age 50. But with the trend of finding colon cancer in younger patients, we did, or the societies did move the starting age to 45, just to try and catch these patients earlier. So it's a statistic that I have here. In 2020, 11% of all colon cancers and 50% of rectal cancers occurred in those less than 50 years old. So with the change in the guidelines, we're trying to capture these patients earlier. So when do we start? So we start at age 55 now, and this is for an average risk person. So average risk meaning you don't have any family history of colon cancer or a personal history of inflammatory bowel disease. Those would be things that would increase your risk for colon cancer. For people with a family history, we start at age 40 or 10 years younger, or 10 years prior, 10 years prior to the age that the relative was diagnosed with colon cancer, if it would fall before age 40. So for example, if you had a father who was diagnosed with colon cancer at age 40, then we would recommend you start at age 30, which would be 10 years before 40. And a lot of patients want to know, when can I stop having a colonoscopy? So our guidelines recommend continuing to at least age 75, and then past 75, weigh the risks and benefits. And it's very individualized based on the person, how healthy they are, what risk factors they have. For myself and my partners, we generally will recommend doing it up until age 80. And I usually will say that since people have been living longer, up into sometimes in the 90s or close to 100, if you want another colonoscopy before 80 or at 80, I'm happy to do that as long as you're healthy enough to have a procedure done. And we have to weigh the risks and benefits of every procedure when we're going to do it, especially with anesthesia risks as we get older, and risks of doing the prep and things like that. So how do we screen for colon cancer? The most common way, or the way that people think of screening, is doing a colonoscopy. So that's a direct look inside the colon. You look and see directly if there are any polyps. And the nice thing about doing a direct visualization is that you're also going to be able to remove any polyps if they're seen at that same time. So colonoscopy in general, every 10 years if there's no polyps. We do have patients come back sooner, certainly if they have polyps, because then they're going to be at risk for developing more polyps if they already have had polyps develop. A flexible sigmoidoscopy is almost like a mini colonoscopy. It does not visualize the entirety of the colon, but goes up to just the left side of the colon. This has fallen out of favor. We don't really do this anymore. This is what they used to do probably 20, 30 years ago. If this is how you decide to get your screening done, and like I said, most people would not offer this. This would be done every 5 years. Virtual colonoscopy is done with a CT scan. A lot of the times we reserve this for patients who have a lot of risk factors for colonoscopy, and we don't think that they would tolerate the procedure well or tolerate anesthesia well. This is done every 5 years. The downfall of doing the virtual colonoscopy is that if it does show a polyp or something that needs further evaluation, you would have to then proceed with doing an actual colonoscopy, so that tissue could be obtained. And then there are stool tests available now. The Cologuard is probably the one a lot of people are most familiar with now. This is testing for the DNA of polyps in the stool. If this is negative, this is recommended to be done every 3 years. FIT tests are also done a lot by the primary cares. This one does not measure the stool DNA. This one is more of a looking at more of a microscopic blood. So this is done yearly. And then the fecal occult blood test, this one's been around for a very long time. This is done annually as well. And certainly if any of these were to become positive, then you would go to a colonoscopy. When these first came out, especially the Cologuard, there were issues with insurance covering a colonoscopy as screening if this were to be positive, and they would consider a colonoscopy diagnostic at that point. So there were issues with patients having to pay more out of pocket for a colonoscopy following one of these positive stool tests. The insurances have come around now, and for the most part, they're still treating a follow-up colonoscopy as a screening now, but there are some insurances that will still consider a follow-up colonoscopy to a positive Cologuard or a positive FIT test as a diagnostic, and no longer a screening. And so if you decide that you want to go with a Cologuard or a FIT test, I would recommend checking with your insurance company to see if how a colonoscopy would be charged if it were to come back positive, because there may be a higher out-of-pocket expense for that follow-up colonoscopy. And this is just a diagram, a cartoon diagram of what a colonoscopy is. So basically what we're doing is this long tube, it's about the size almost of like a pencil. It's about a little less than a centimeter in diameter, but it has a light on the end, and it has channels that we can put our tools through to remove polyps. But what we're gonna do is we're gonna snake this through the rectum and bring it through the large intestine, all the way to where the large and the small intestine meet. And then we're gonna be looking for any polyps. And so polyps are gonna be those little growths on the inside. And then through that channel, we can put our tools through to remove them. So in this cartoon, this is a snare device, which is just gonna loop around the polyp, and then we pull that tight and it cinches off that polyp. And then the colonoscopy tip has a suction catheter, or a suction port, I'm sorry, at the end, which we can suction up that tissue so that we can send it to the lab to be analyzed to see what type of polyp it is. And then certainly a normal colonoscopy would not see any of these little polyps. And then just general information about a colonoscopy. On average, it usually takes about 20 to 30 minutes. We do all of our procedures in Muskegon with anesthesia, so everyone's asleep during the procedure and comfortable. Now, as far as, I guess I should go back over here. So if we do find any polyps, the repeat colonoscopy does range based on that type of polyp. It can range anywhere from 3 to 7 to 5 or to 10 years if those polyps are those benign hyperplastic kind, the kind that do not have cancer potential. And then we also base your repeat colonoscopy on how big the polyp is. So larger polyps that are bigger than a centimeter inherently will have a higher risk of turning into cancer later on if they're not removed. So we do bring you back sooner versus a small little one that's 1 to 2 millimeters in size. Now, if we find a colon cancer, there are different treatments available. Most common is going to be surgical removal of that spot that has the cancer. If it's caught early, then that's all the treatment usually that you would need. Cut it out. The surgeon usually will hook you back together, usually no bag, a colostomy bag, and just follow up colonoscopies after that to make sure the cancer hasn't returned. Certainly, if things have spread out of the colon, then that's when we're looking at more chemotherapy and radiation. I am not by any means a cancer doctor, so I'm not going to go into detail about those options. But as a general rule, if the cancer has spread out of the colon, then that's when you usually will need chemo or radiation. Radiation is going to be more for the lower cancers that are in the rectum. Those usually will be treated with radiation first before having surgery, but that does really depend on the location of the cancer, how much of the colon or the rectum is involved, and if the surgeon thinks they would be able to remove it all at that time. Sometimes, like I said, they will do radiation first to shrink things down before surgery. And of course, everything is based on each person with their underlying health issues, location of disease, and if it's spread outside or not. And then once I diagnose a colon cancer, I usually will send patients to both surgery and oncology so that their treatment plan could be decided on their individual basis. I do have a slide here with different websites for you guys to look at for general information. These are through our GI Society, so these are all guideline-based information there. And that's pretty much the end of my talk. So if you want to open up the questions, Brittany.
Yeah, excuse me. Yeah, thank you so much. We can definitely transition into our question and answer portion. Just a reminder that if you do have any questions, you can use that Q&A chat, which is, they kind of look like two speech bubbles near the bottom of your screen to submit your question. If there are any questions that we are not able to get to or that maybe need some additional follow-up, we can include those in the follow-up email that we'll be sending out. That will also include the link to this presentation. So we do actually have a few questions that we received prior to the presentation, as well as a few questions that have come in since the presentation has started. So Dr. Yim, if you're ready, I will go ahead and I will read those questions out loud.
Okay.
And then we can just kind of get those answered. So one of the first questions that we received prior to the presentation was if there is a way to prevent colon cancer or a way to reduce the risk of developing a polyp.
Sure. A lot of the basis for polyps is going to be your family history. So unfortunately, that's something you would not be able to change. I will say that in general, fiber is really good for colon health. So getting a high fiber diet in is really good for the colon. Avoiding smoking is one of the bigger lifestyle things that we can do, and avoiding alcohol. These would be the lifestyle things that people can do to try and reduce their risk of developing polyps. Unfortunately, like I said, if you have a family history, that's something you just unfortunately cannot change.
Thank you.
Yep.
Would other types, sorry, this is another question for you. Would other types of cancer and first degree relatives also increase your risk, or is it specific to colon cancer?
Oh, so that's kind of a big question. So there are some other cancers that can increase the risk for colon cancer. The main one is going to be breast cancer. And a lot of times people will get their genetic testing done, and there is one mutation. If people have breast cancer and they test positive for the MU2 mutation, then that can increase the risk for colon cancer. And so for those patients, we usually do those early and then treat them as if they, they have that higher risk. That's the main other cancer.
Okay, thank you. Okay, kind of switching topics here. Next question is regarding probiotics and how do you know if they're working for you?
So that's an excellent question. Probiotics, not FDA regulated. None of the supplements or vitamins over the counter are going to be regulated. And in general, what I usually recommend when my patients ask me this is I would give a probiotic a good 4 to 6 week trial. And it also depends on what you're taking it for. So a lot of the times patients are taking it because they have a change in the bowels, whether it be diarrhea or constipation, usually diarrhea. And so I'll tell them you can start taking it. And if you don't notice a change after 4 to 6 weeks, then you probably are not going to notice anything past that. So I would just stop taking it after that trial. Studies have shown that the results of taking probiotic are really equivocal. It did not make a significant change. There was no statistical significance with taking probiotic and improving those kinds of symptoms. So I don't, I recommend trying it, but I don't tell patients to continue with it if they don't see any difference after about 4 to 6 weeks.
Thank you. The next question I think you may have touched on briefly, but asks, what are the potential risks for having a colonoscopy?
So risks of colonoscopy, the biggest one is going to be bleeding, and that's an inherent risk with most procedures where you're removing tissue. So that's usually the biggest risk. That's going to be higher risk in patients who are taking blood thinners. So if you're on a blood thinner, we do usually reach out to the prescribing physician for that to make sure that that's something that could be held. There's also a risk for tear damage to the lining of the colon wall, so like a tear or perforation. There's also risk of infection. Those three are probably the biggest potential complications of a colonoscopy. Very rare to get one of those complications. In general, statistics, less than 1 in 1,000 chance of that happening, so less than 1%. But the highest risk of those three is going to be bleeding. And then larger polyps do have a higher risk for that to happen. And certainly during the procedure, if I take off a polyp and it seems like it's oozing more than it should, or if someone is on blood thinners, I usually will put a clip to close that defect to try and prevent any bleeding from happening once you go home. If there is active bleeding during the colonoscopy, we do have other modalities to treat it. So we can do cautery or burning to the area to stop the bleeding. We can inject medication. So as far as that complication goes, even though it's the one that occurs the most often, it's also something that's easily treatable for us at the same time.
Thank you very much. Next question asks if there is a substitute for colonoscopy prep. Would fasting for a few days properly clean the colon?
That unfortunately does not work. So the colon, even if you're not eating, your colon is still producing mucus and still producing, or your body is still producing bile, which gets secreted into your intestines. And so if you're not taking a prep to wash and cleanse the wall of the mucus and of the bile, it's going to be very difficult for us to visualize the lining of the wall. And the whole point of doing the colonoscopy is to visualize the lining so that we can see the polyps. So unfortunately, everyone does have to do a bowel prep. There are different types of bowel preps available. So if you had a bad reaction to that regular prep, there are other options available, and that's something that you could always ask to talk about.
Thank you. We have quite a few great questions. The next one is a really great one is when is it necessary to consult a gastroenterologist?
I think I would need more information, like as far as doing a colonoscopy, or are they having trouble with their bowels? Certainly, if you're having issues with your bowels, it's always great to see, at least start with your primary care. And if it's not something they could handle, then a referral to a gastroenterologist.
Perfect, thank you. Next question is, how does gluten affect the colon?
So gluten does not affect the colon, which is the large intestine. Gluten affects more of the small intestine. And so what it does is it destroys the finger-like projections that are on the small intestine so that you're not absorbing any not absorbing the nutrients that you're eating. Gluten doesn't affect the large intestine.
Thank you. The next one says, so much is said about green tea. Does a daily cup of green tea help reduce risk of colon cancer?
So I actually have not seen any studies about green tea and colon cancer. So I would have to defer an answer on that. I don't know any studies that have done any correlation or any kind of cause and effect of green tea on colon cancer.
Okay, thank you. Next question is, what part or area is most common for polyps?
Oh, that's an excellent question. So I'm going to bring that slide back up where I have the colon. So the more the more this area here that is the right side of the colon. So the way this picture is if it were laid, it's a mirror of how you are. So this is the right side of the colon, and this is the left side of the colon. The right side of the colon, these polyps over here traditionally have been the more precancerous ones, have a higher risk of turning into colon cancer. However, the trend now with younger people being found or being diagnosed with colon cancer, we're actually seeing it more on the left side. So that's kind of hard to give a definitive answer, but traditionally, usually the right side is where we tend to see more of the precancerous polyps, but the trend is now to see them on the left side.
Thank you very much. The next question asks, how does dairy affect the digestive system?
So Dairy is absorbed by receptors in the small intestine, and it breaks. It's broken down by lactase, or breaking down that lactose. So a lot of the times, as we age, we lose those receptors, and so we tend to see that people have more of an issue with dairy as you get older. And Asian population does tend to have less of that enzyme, the less ability to break that down. So that's why we usually see more of a lactose deficient or a lactose intolerance in that population. But we do tend to have a harder time breaking down dairy as we get older, just because we just don't have that enzyme capability.
Thank you everyone for joining us this evening. Thank you to Dr. Yam for a wonderful presentation. And we really appreciate you being here with us. And we hope that you are able to join us for our next Wednesday Wellness. That presentation will take place on April 24th at 7 p.m. And thank you so much again. And I hope everyone stays well.